We can make it full screen, sir.
Yeah. Just give me a second.
Not yet, sir. You just
Yeah. It's not in full screen.
Yeah.
Thank you, Amari. Thanks for that kind introduction. Thank you very much for inviting me for this lecture. Only when I started preparing for this lecture, only I realized that imaging in respiratory diseases is like a big topic for 20 minutes. I think next time you all do this, it will have to be sort of a more focused topic, I suppose. So why image? Imaging, I mean, any disease, imaging is a central part in management of any disease these days. It confirms your clinical diagnosis, and it gives you a differential considerations, and it gives you the disease extents and associated abnormalities. It definitely impacts the management and also to follow up and assess a treatment response. Most of this lecture is based on this nice article by Professor Edward Lee of Harvard University. It's called the Pediatric Chest Disorders. So they describe these pediatric chest or chest diseases in a 3-compartment model. First is the primary process of the lung parenchyma. Second is the abnormalities of the large airways, and then the pathologies originating in the mediastinal. Chest radiography. So we have several imaging modalities to image the chest. The commonest one is the chest radiography. It has been there since probably 1896, providing a unique and immense service to the mankind. Because of its diagnostic yield and easy acquisition, it's the most commonly performed imaging modality in the chest. But you always have to think of the ionizing radiation, which is the main drawback. Because unlike in adults, in children are more susceptible to effects of ionizing radiation, and they live longer. So potential for repeated exposure as compared with adults, you have to be very careful when you are exposing children to radiation. Because all of us are involved in radiation work, as clinicians, you all are ordering, and as radiologists, we are performing. We need to know a little bit about radiation protection. So the basic principle of radiation protection is what you call this LRA principle. That is, radiation levels you have to keep as low as reasonably achievable. You need to know a little bit about this. Image Gently is an international society with a lot of countries participating to bring down the level of radiation exposure in children. If you need to see, like if you're having any doubt whether you need to do this radiation imaging in a child, whether this is really required or whether you can do something else, you can go to this Image Gently website and look it up and see whether you can do anything else for that or how we are going to proceed with that. Coming to CT, with chest X-ray and CTs, we can see almost 95 or 98 to 100% of diseases with chest X-ray and CT in chest. When do you use contrast? When you don't have to use contrast in CT? If you are seeing only the lung parenchyma, you don't have to use contrast. Like say, if you are looking for bronchiectasis, maybe bronchopulmonary dysplasia or meconium aspiration syndrome, things like that. If you want to confirm, you don't need to give contrast. But if you are assessing a lesion, if you are looking at the great vessels or the mediastinum or the hilar regions, you have to give IV contrast. These days, multi-detector CTs are very helpful, especially in pediatrics perspective, because it gives, like, in Sri Lanka, we have like 640 slice CTs with very rapid acquisitions. In seconds, you can cover the whole chest. So you have less respiratory and motion artifacts, and you don't have to sedate the child. But people have the notion that multi-district CTs give less radiation. It is not so. Sometimes it may give more radiation than conventional CTs. But these days, almost all our CTs are multi-detector CTs. Again, the disadvantage is ionizing radiation. So few indications. Chronic lung disease is a definite indication. If the child has chronic symptoms and lung chest X-ray abnormalities, you want to further clarify, you have to do what HRCT, a non-contrast HRCT. Even if the child does not have chest X-ray changes, it is not a contraindication. Sometimes when the children have prolonged symptoms and the normal chest X-ray, you need to do HRCT to find out what's happening. Then infections, you can look for complications of infections with a CT, but for a simple pneumonia, community-acquired pneumonia, you don't have to do a CT. A chest X-ray is more than enough. Even abscesses, empyema, and necrotizing pneumonia, you can see with your CTs and possibly with ultrasound, but most of the time, if you are referring to a surgeon and if you are following up and if the patient is not well, you need to go and do a CT for better assessment of the lesion. Tumors, obviously you will need contrast CT. Trauma, if there's a significant history of trauma, a chest X-ray may not be sufficient. You will need a contrast CT so that you can see the fractures, the mediastinal hematomas, lung contusions, any damage to the great vessels. Obviously, great vessels, cardiac CT, and complex heart diseases, you need a CT. More and more, we are trying to get into MRI for cardiac diseases. And in neonates, diaphragmatic hernias, pulmonary sequestrations, etc., you need assessment with the CT. When talking about the radiation exposure, what you have to remember is that most of these malignancies, you have a very long latent period. So leukemia, breast cancers, sarcomas, and thyroid cancers are some of the malignancies which are related to radiation exposure. As you can see, the latent periods can be maybe 30 to 40 years. So what we order now and the radiation exposure we give to the child, the results we may not see for a long time, and we may not see during our lifetime. So you have to be careful. You have to always justify when you're ordering radiation-related imaging. But having said that, you need to know that radiation exposure, especially when it comes to the chest X-ray, is not all that high. With these new machines, as you can see, if you are just standing here, you are exposed to background radiation. That is calculated to be 3 millisieverts per year. Millisieverts is the unit we measure radiation. So chest X-ray, it's just 0.01 millisieverts. That is equivalent to 1 day of background radiation. If you do a CT brain, that is 2 millisieverts. It is equivalent to about 8 months of background radiation. And a chest CT, it's about 3 millisieverts. So it is not a big radiation dose, but the problem is that with a child, as I said earlier, there's a long latent period and they will live a longer time. So they will be exposed, possibly be exposed to multiple exposures. So there's a cumulative effect. So to be careful when you're ordering X-rays or CTs. So fundamental principles in radiation protection are, because I think all of us need to know about radiation protection in a child. Optimization and dose limitations are like a job of the radiologist and the radiographer, but justification starts with the clinician. When you order or when you're thinking about ordering a radiation-related imaging, you always have to justify whether this is needed, whether you are going to get the needed data or requirements from the things you have ordered, like the CT or the chest X-ray, or whether you can choose another investigation such as the MRI or ultrasound. If you're in doubt, you can always ask your radiologist colleagues, or you can refer this American College of Radiology or Royal College of Radiology guidelines where they have given appropriate use of medical imaging for specific clinical conditions, and most of the clinical conditions are given in these. So always weigh the benefits of a specific examination against the possible risk of radiation. MRI, we don't use much for lung parenchyma because it is restricted. Images are restricted by intrinsic paucity of photons within the airfield alveoli, so you don't get many MRI signals to generate a good image. And though we use respiratory and cardiac gating, still there are motion artifacts limiting the use of MRI in children. But of course, lesions, soft tissue lesions of the mediastinum and soft tissue lesions of the chest wall, it is better than CT for assessment. The last but not the least is ultrasound. It is probably heavily underutilized in our settings, but more and more, especially in the ICU setups, they are using ultrasounds for assessment. You can assess the pleural fluid even less than 10 ml. You can see in a erect position in the pleural space with ultrasound. You can see whether it is turbid, whether like it's infected, whether it has bled, or you can see septations, because if there are no septations and if it is large, you can aspirate. And opacity you see on the chest X-ray, if you're not sure it is a consolidation or a fluid collection, you can easily keep the probe and see whether it's a cystic or a solid lesion. You can see pneumothoraces with ultrasound. Then in neonatal lung, like in diaphragmatic hernia, it's very helpful. If you have anterior mediastinal whiting and if you're not sure whether it's a thymus, sometimes the thymus can be very big normal thymus can be big in children, and an anterior mediastinal mass like a lymphoma, you can easily keep the probe and differentiate thymus from an anterior mediastinal neoplastic lesion. Then, as I said earlier, empyema, abscesses, necrotizing pneumonias, all these in children you can diagnose because most of the lung is close to the surface, unlike in adults. But if you need further clarification, of course, you have to go for a CT. There are two things that always people ask: what is this lung hepatization? It's like when the lung is consolidated, it looks like the liver. And you may see air bronchograms, or if the bronchi are filled with fluid bronchograms on ultrasound also. Coming to specific infections or specific diseases, we'll talk a little bit about pulmonary infections in children. Viral pneumonias, they can be quite common. What you have to remember is that your chest X-ray findings can be there only after about 4 to 7 days after the onset of illness. You don't have typical appearances in viral pneumonias. What happens usually is that the viral migrates distally and the inflammation is in the distal bronchioles and in the alveoli. So there is inflammation and air trapping causing hyperinflation of the lungs. Usually there are bilateral changes. Commonest findings, they say, is a reticular pattern in the lung bases, usually bilateral. You can get bilateral patchy areas of consolidations and diffuse areas of airspace consolidations and lobar consolidations also you may see. But commonest finding they have found in many articles and many researchers is reticular pattern or reticular nodular pattern in the bases, usually bilateral. This is a X-ray of a child with a viral pneumonia. As you can see, the bases are more involved. You can see increased reticular shadows. There are some reticular shadows in the upper lobes, and these small patchy opacities are small areas of consolidations. This child does not have air trapping. There's another child, X-ray from another child. You can see increased interstitial shadows. There's a little bit of relative sparing of the left upper lobe, but mostly the bases and the perihilar regions are involved. no consolidations, but he has a little bit of air trapping as indicated by a little bit of flattening of the diaphragms. So what are the complications of viral pneumonias? Usually what happens is they get a superadded bacterial infections. On imaging, it will look like any other bacterial infections with lobar or segmental consolidation. But other important sequelae of viral infections are bronchiectasis, post-infectious bronchiolitis obliterans, or a similar thing called the Swyer-James or McLeod syndrome. A little bit about post-infectious bronchiolitis obliterans. It is not uncommon, especially in a tertiary care setup like ours. We see post-infectious bronchiolitis obliterans infrequently. It is a irreversible chronic obstructed chronic process due to recurrent or infections with viral pneumonias. Main thing is that though the child is having symptoms, the chest X-ray can be non-specific or even normal. So you always have to go for HRCT. Non-contrast HRCT is more than enough. So what are you going to see? You will see peribronchial thickening and bronchiectasis and mosaic attenuation in both lung fields or maybe the unaffected segments, and the reduced vessel size in low attenuated areas. These are the typical findings you see with the bronchiolitis obliterans. Swyer-James or McLeod syndrome is also a form of bronchiolitis obliterans. It can involve one lung. If it is unilateral, it can be the whole lung, or sometimes it can be a lobe, or both lungs can be involved. Again, the involved segment or the lung can be hyperlucent due to pulmonary hypoperfusion. Then you will have a small pulmonary artery and a small hilum, and you will see reduced volume in the affected lung with air trapping. This is a patient with a Swyer-James. You can see that the pulmonary artery is small. The pulmonary, there is hypoperfusion of that lung indicated by small and few number of pulmonary vessels, and there is loss of volume. But this does not see this child does not have increased lucency in that affected lung. So same child, if you do the HRCT findings, as you can see, the left lung is small. Though you could not see it in the chest X-ray, he has peribronchial thickening and mild bronchiectasis in the lower lobes and hyperlucent areas with small vessels. Though you could not appreciate the changes in the chest X-ray, now that in the CT, HRCT, you can see that the other lung is also involved with areas of mosaic attenuation. Coming to bacterial lower respiratory tract infections, what you will see are unilateral, commonly segmental or low-by space opacifications or consolidations. Sometimes you see expansile pneumonias caused by Klebsiella or Staph aureus. But in early bacterial pneumonias, you may see interstitial opacities, but they are not specific for either viral or bacterial pneumonia. What you can say is that if you see interstitial shadows, that there is an inflammation going on, but you can't say whether it is a viral or a bacterial infection. So this is a expansile pneumonia involving the right upper lobe. You can see that the fissure is compressed inferiorly. There is no air bronchogram, but because the child was not improving, repeat X-ray was done a few days later. It's showing a necrotizing pneumonia. The area is starting to get necrose. Necrotizing pneumonia is developing. If it is a simple community-acquired pneumonia, you don't need to do a follow-up X-ray if the child is improving with antibiotics. Then another specific conditions in children is a round pneumonia. Usually you see in less than 8 years of age. It happens because there are immature collateral pathways and the spread of infection is limited to that specific area. Usually caused by streptococcus, but Klebsiella and Haemophilus influenza also can cause round pneumonia. Why is it important is that sometimes you can confuse this with a mass because it's a solitary well-defined round lesion. Sometimes it can be large up to about 4 centimeters. You usually see it adjacent to a pleura in lower lobes, but you may see it in the upper lobes also. The thing is that you may not see an air bronchogram. If you see an air bronchogram, it's easy. You will know that this is a consolidation. But even if you don't see a bronchogram, if the child is clinically responding to your treatment, you don't need to do a follow-up X-ray even. This is a round pneumonia. Unfortunately, this child also doesn't have a proper air bronchogram. But if you treat and the child is clinically getting better, it will disappear after a few days. Another common condition or condition clinicians are worried about is a mycoplasma pneumonia. It's an important treatable cause of community-acquired pneumonia, and because it lacks a cell wall, it is insensitive to the normal antibiotics. Unfortunately, again, Mycoplasma pneumonia also does not have a typical chest X-ray pattern, but they say that if you see a focal reticular nodular or reticular nodular pattern in a focal area of the lung, it is with your clinical picture, it will probably indicate a Mycoplasma pneumonia. But as they progress, they can get focal consolidations, diffuse interstitial patterns, adenopathy, effusion, and air trapping. So there are these are few X-rays from proven Mycoplasma pneumonia. In the left upper X-ray, you can see the left upper lobe, localized increased interstitial shadows, nothing in the right upper lobe, nothing in the left upper lobe. In the left lower X-ray, you can see in the right lower zone, increased interstitial shadows. Again, the left lower zone is clear. Same thing with the right lower X-ray. And upper X-ray there, that left upper, increased interstitial shadows in the left lower lobe, and he's developing a small patch of pneumonia also, consolidation. So coming to large airway diseases, subglottic hemangiomas, this is usually you see in small children like infants. It's a benign neoplasm, but it obstructs the airway, and it's the commonest obstructing subglottic soft tissue mass in children. Though it is benign, if you don't diagnose and if you don't treat, the mortality can be up to 50%. As with the typical hemangioma, usually they are there at birth, but as with the typical history of hemangioma, they grow slowly. So the children present usually around 2 or 3 months due to enlarging size, and they can present with stridor, feeding difficulty, or even hemoptysis. X-ray usually has a classic appearance because the subglottic trachea will be compressed from a side. So as opposed to infections like flu, you will see when there's infection, you can see circumferential narrowing of the trachea. But when you have a mass like a subglottic hemangioma, you will see the trachea getting compressed from a side. But X-ray is not enough. You will need either CT or MRI to assess it better. You will see an enhancing lesion in the subglottic region. So this is the X-ray. You can see the lateral indentation. If it is an infection like a croup, you will see a circumferential infection of the trachea. This is the enhancing lesion. It's quite small. Treatment used to be surgery, but because these lesions are vascular, they are difficult surgeries. But these days it has changed. Now people give sclerotherapy, beta blockers, and various things, and even laser treatment for hemangiomas. Then another common condition of the airway which can affect children is a tracheomalacia. It's described as dynamic and disproportionate collapse of the tracheal lumen with expiration. You can see it in both premature and term infants. They also will come with recurrent lower respiratory tract infections, wheeze, or stridor. But classically, the symptoms will worsen with activity or agitation. You have to be careful with X-ray. X-ray is usually not enough because when a child is crying, the trachea can collapse up to 50% of its diameter. So narrow trachea, because when you have the X-ray, you don't know whether the child has cried at that time or not. So a narrow trachea may not indicate a lesion or a tracheomalacia. So if you suspect a tracheomalacia, if the child has symptoms, ideal thing is to do a CT. So in books, they describe inspiratory and expiratory series, but usually in our settings, we usually do one CT that is usually adequate to diagnose tracheomalacia. On the left-hand side is a CT. In inspiration, you can see the distended trachea, but in expiration, it has markedly collapsed, less than 50% of the diameter of the lumen. The same child with 3D reconstruction, you can see the nice images. So it's not only the trachea that is affected, you can see that multiple areas in the bronchi are also affected. That is a bronchomalacia. A little bit about foreign body aspiration because it's very common. Chest X-ray is the first line imaging. As soon as a child comes, you will take X-ray. But you have to remember that only 10% of the foreign bodies are radio opaque. So you are looking for indirect signs. Usually the commonest sign will be a unilateral hyperinflation of the lung. So if a foreign body is in the right lung, there will be hyperinflation of the right lung. But there are other indirect signs such as localized air trapping, focal consolidations, pleural effusions, mediastinal shift. If there is a collapse caused by the foreign body in the bronchus, you will see the mediastinal shift to the same side. Or if there's air trapping, the mediastinal shift will be to the other side. If it is complicated, you may see pneumothorax or subcutaneous emphysema also. If you're not sure, you can go for a bilateral decubitus radiographs, left lateral or right side down and left side down. But they have found that it's only about 70 to 75% sensitive. So best thing is if you are suspecting a child with a foreign body, you have to do a CT for confirmation. Otherwise, they will come with chronic symptoms, or they can, with sudden aspiration, they can even mortality also may be high. So just to illustrate, this is a chest X-ray. The first X-ray shows slightly hyperlucent right lung. So because you're not sure, we have done a left decubitus or the left side down. When the left lung is down, the left side down is down, you can see the air has gone out, so the lung has reduced in volume. For the same child, you put the right side down, that lung, because there is air trapping, the volume has not reduced. So it indicates that there's air trapping in the right lung. So it just shows you that there is air trapping, but it doesn't show foreign body. So you have to go ahead and do a CT. Just a little bit about mediastinal masses. So if you have differential diagnosis for anterior mediastinal mass in children, and both in children and adults, are lymphoma, thymoma, teratoma, and sometimes you can get acute lymphoblastic leukemia also coming as masses, and not so commonly vascular and lymphatic malformations. You need to know a little bit about lymphomas in the anterior mediastinum. Usually, child will present with stridor, wheezing, difficulty in breathing, and changes of SVC obstruction. When they come, the lesions are very large. We see large lesions most of the time in our children. So they will come with pleural effusions, tracheal compression, pericardial effusion, and lung collapse problem. You have to treat this as an emergency, and you have to do a CT as soon as possible, though the child is having airway difficulties, but you have to give contrast, otherwise it is very difficult to assess. So you have to assess the airways, vena cava, superior and inferior vena cava, pericardial and pleural effusions. So if the child is in breathing difficulty and if he has a tamponade, you may have to aspirate both the pericardial and pleural effusions. But at the same time, if you are giving sedation, you have to do a biopsy also. As soon as you see a anterior mediastinal mass, you have to inform your oncologist. That's what we are trying to do at LRH. Because this is emergency, you have to do things very quickly. Otherwise, if you take a few days, the compression may be more and you may not be able to do a biopsy at all. So you have to get the pediatrician, oncologist, radiologist, anesthetists, and all these people involved and do the biopsy as soon as possible. And always, even child is having wheezing or allergy, always ask the oncologist whether we can give steroids, because once you give steroids, the tumor size comes down and it may not be possible to give, do a biopsy, and the tumor architecture also changes, and the pathologist may find it difficult to give you a diagnosis. You have to do a biopsy on the bone marrow. It carries a risk, but this is something you have to do if you need proper treatment. So usually we do it under ultrasound guidance, patient in the recumbent position so that it is easy to breathe. With light sedation, we do the biopsies. Because of the time constraints, I will just skip the vascular lesions. And most of the time, the vascular lesions are diagnosed by the pediatrician. They suspect the vascular lesions and send to the cardiologist. Cardiologists usually diagnose these and send to us for further assessment. So it is not a first up diagnosis with your chest X-rays or a CTs. Just a little bit about non-neoplastic lesions. You get duplication cysts in the mediastinum. They are not all that uncommon. They can be either bronchogenic, esophageal duplication cyst, or neuroenteric cyst. If you look hard enough, if they are big, of course, you will see it in the X-ray. But if you look hard enough, even when they are small, you will see it in the chest X-ray. But chest X-ray is not enough, because the differential diagnosis always is if you see opacity, rounded opacity, is a tumor. So you have to do a CT or MRI. As you can see, there's a posterior mediastinal mass. You can see the subtle change. But if you do MRI, you can see the cyst nicely. And two more conditions, just to talk about the posterior mediastinal masses. If you see a posterior mediastinal mass in children, it's almost always a neurogenic tumor. The spectrum is ganglioneuroblasts, ganglioneuromas, which are benign, neuroblastomas, which are malignant, to ganglioneuroblastoma, which are intermediate. Small children, you will see neuroblastomas. The higher the age, you will see ganglioneuroblastomas and the ganglioneuromas. As opposed to the abdominal neuroblastomas, mediastinal neuroblastomas are more benign. So depending on the site of the lesion, the symptoms may differ. But if you see calcifications, most of the time in a younger child, it will be a neuroblastoma. But the X-ray is not enough. You always have to go for a CT. And if it looks as it is extending into the spinal canal, or if you are seeing any cord symptoms, you have to do MRI. So this is a X-ray shows a large posterior mediastinal mass. Why I say it's a posterior mediastinal is you can see the anterior lung marking nicely. Lateral chest X-ray will clearly show you the posterior, the place of in the posterior mediastinum, and you can see the calcifications and the large mass, like the neuroblastoma in the posterior mediastinum in the CT. So the last is a lymphatic malformation, which is not very common in our settings. Isolated lymphatic malformations in the mediastinum are not common. Usually they extend from the chest wall or the axilla. Why it is important is that when you do a CT, even sometimes you can confuse it with a lymphoma, because both the lymphatic malformation and the lymphomas may not enhance. In fact, we had a child about a few months back who came with a large CT done elsewhere. So we didn't want to do another CT because of the radiation. And we went and we wanted to do a biopsy, but when I went and kept the ultrasound probe on the chest to see that it was a multiple, there's a large lesion with multiple cysts with a macrocystic and microcystic components. So if you see something like that, the MRI is the gold standard. So ideally, the soft tissue lesions are better characterized with MRI if you can get MRI. Treatment is surgery and sclerotherapy. Most of the time, sclerotherapy is good enough. Thank you very much.
Thank you, sir, for that very comprehensive account on imaging in respiratory diseases. Just 1 second. May I stop sharing your presentation, sir?
Yes.
Yeah. Next is the time for questioning. We would give.
How does Seretide proactive regular dosing help patients achieve better quality of life? Since I started using Seretide, I feel like my asthma is finally under control. I can focus better at work and give it my all every day.
Nowadays, I almost forget that I have asthma. It's kind of hard to take care of others when you're wheezing and feeling breathless, you know? That's why it's so important for me to take care of myself.
I haven't reached for the rescue inhaler in a long time. Ever since I started my daily Seretide discus routine, I find that the attacks are less frequent and less intense. It helps me do what I love the most, my daily yoga class. Namaste.
Help patients embrace their everyday with Seretide proactive regular dosing.